The following is a paid advertisement of St. Anthony Hospital Orthopedics. References to any specific product, services, or entity does not constitute an endorsement or recommendation by St. Anthony Hospital, Carroll Broadcasting, or its advertisers. The views expressed by the host or guests are their own, and their appearance on the program does not imply an endorsement of them or any entity they represent. Welcome to the St. Anthony Hospital Orthopedic Show with Dr. Richard Godding. Dr. Godding specializes in joint preservation, reconstruction, and replacement surgery, and brings over 25 years of orthopedic excellence to St. Anthony Hospital and to the Carroll area. For more information about Dr. Godding, his practice, or St. Anthony Orthopedics, go to santanthonyhospital.org or make an appointment by calling 712-794-5536.
Good Sunday morning, Iowa. It's Dr. Rick Godding. Thank you for choosing to spend some time with me here today. And it is, as I'm recording this, walking into the studio today was nasty. It's nasty. And I'm sure the farmers could use some rain, but a little rain and a little cool off would be nice for everybody. But it's turning the corner here. It's almost fall. My youngest daughter's sweet 16 this week, and my oldest daughter is now 2 weeks away. 2 weeks away from heading off to college. And so I think I've dealt with all the bittersweet emotion, I'm sure, when I drop her off a ball. But here we go. We're on the way. So today I wanted to talk about back pain and sciatica and what the differences are, and I think people have some different ideas as opposed to what's actually the case. So, first of all, back pain is localized to the back. I know that sounds redundant, but when we talk about low back pain, we're talking about just pain in the lower back, and that typically comes from, it can be arthritis. If you're younger and you don't have arthritis, it can be from a strain, but it's localized in the back. It's very rare to ever have surgery on back pain itself. And most people that have had back surgery have it because they had leg pain. And I'm going to explain the anatomy on that and how sciatica relates to all this. So the spine, let's start with the spine. So the spine is all of your vertebrae that start up in the neck, right underneath the brain. And the brain comes down and goes through the middle of the canal that is formed by the vertebrae. The vertebrae have the bone, the supporting bone is in the front, and then in the back they have a little ring, and through that ring flows the spinal cord, or runs the spinal cord. And at each vertebral level, so in between the first one and the second one, all the way down to the last one, in between there, nerve roots come out. Those nerve roots will send signals from the brain and back up to the brain. So the brain converts into the spinal cord insofar as you got your brain, and then you have what's called the brain stem, where everything is kind of funneling down, and then past at the area of what we call the first cervical, basically the first vertebrae in your neck, vertebral body in your neck, the foramen or the hole in that, as it passes through that, it becomes the spinal cord itself. Now the spinal cord does not generate any signals. The signals are all generated from the brain, and they're transmitted down the spinal cord and then out the nerve roots. So one nerve root going left and one nerve root going right at every level, all the way through the cervical, lumbar, or cervical, thoracic, and lumbar. So the cervical spine's in the neck, thoracic is in the chest, and the lumbar is in the below the chest, all the way to the lower back, to the end of the sacrum, which is your tailbone. And there's nerve roots coming out left and right, and those nerve roots have nerves in them, some that are going out with a signal and some that are coming back with other signals. So your brain tells your hand to move. That's one signal pathway. Your hand touches something and you feel it. That's another signal pathway. And then reflexes are what happens when, like, a pain will come or an input will come, and the signal will come up to the brain and back down without you having to think about it. I mean, if you put your hand on a hot plate and it's starting to burn, you don't have to stop and think, my hand is burning. I'm going to move it off. By that time, your hand is back behind your head, you hope. So basically the spinal cord is wires. The brain is the computer, and the spinal cord is the wires that takes the signal from the brain out to the muscles, the heart, the intestines, the kidneys, all your organs. And then each of those have signal pathways, and they're sending information back so that your brain knows what is happening in the body. And so when we get down the vertebrae, so those are the bones in the spine, all the way from the cervical right under the brain that the skull rests on, all the way down to the tailbone, those are all resting on top of each other, and there's motion there. And there are multiple little joints that we call facets. And these joints allow, the rotational motion that you can get in your spine, and the forward and backward, the flexion and extension motion. And all of those motions are dependent on these joints. And when those joints start to hurt, when those joints start to get damaged, they can hurt. And that's where you're getting your low back pain. Usually it's from one of those joints is starting to get a little arthritic, or maybe it's just a little inflamed or whatever. And the treatment for that is typically, we're going to start with physical therapy and anti-inflammatory medications. There are some cases where spine surgeons will do a spine surgery for back pain, but it's not very often because it's just not that successful. Now, that's not saying I don't know what the percentage is, but it used to be 90+% of back surgeries, lower back surgeries, are for leg pain and weakness and things like that. So there are different ways that the nerves, as they exit, can be compressed, and that's where your symptoms are coming from. So the nerves can be compressed by bone spurs on the joints. They can be compressed by the foramen, which is the canal that the nerves exit the spine in. That can just get overgrown with either synovial tissue, which is sort of the joint tissue, or bone itself can grow. Or you can have a disc. So there's discs in between each of these vertebrae to cushion them. And those discs, you've heard of a slipped disc. Well, what that means is that the disc itself has lost some of its integrity, some of its form, and the gel part of the disc will bulge out past the part of the disc that's not gel, which is sort of like a border. It's like a cartilage border that holds that gel in there, so the gel can act as a cushion. So as that pushes out, that can impinge on one of those nerves as well. Now, we're not going to talk about it, but there's another way that the spinal cord itself can actually get compressed through the main foramen, which is not the little ones that the nerves come out, but the one that the spinal cord is actually riding in, and that's called spinal stenosis. So spinal stenosis can happen, well, I'll talk a little bit about it. Spinal stenosis, again, is where, so the vertebra have these bones in the front, and then they have a ring in the back, and through the ring runs the spinal cord. Now, down in the lumbar spine, the spinal cord becomes all roots. So it's not one cord with little nerves coming off of it like it is up in the neck and in the chest. Once it gets down to the lower back, the L2-3 level, below that, it's all just a bunch of nerve roots, and that's called the cauda equina, which means horse's tail in Latin. So when you have, again, so there's a foramen, there's a spinal canal, which is a main, let's just call it, we won't use the term foramen, it is a foramen, but that just means hole. So the spinal canal, where the spinal cord goes through, and then at the end, the cauda equina, or all the nerve roots goes through, that can also get constricted. And that can be a much bigger problem, because if it's up higher than the cauda equina, or the part where the spinal cord becomes just a bunch of nerve roots and there's no more actual single cord, if it's compressed at the cord level, that can cause some real problems. So spinal stenosis is different than sciatica and nerve impingement, okay? And spinal stenosis can happen in the neck, and nerve impingement can happen in the neck. It can happen all the way down. You can even get spinal stenosis past the point of the cauda equina. It's not nearly as severe, but it's not a great thing either. So when you get down to the lower back, what we started talking about, and what kind of my point is today, because people have a big misunderstanding, that people will come in and they'll say, I have pain running down my leg. I think it's sciatica. Yes, Okay, you have sciatica. What does that mean? That means that the sciatic nerve, which is some nerve roots coming from L3 to S4, so the lumbar, sort of the mid lumbar spine to the near the end of the sacral spine, all of those nerves, as they come out, they then reform into one big nerve called the sciatic nerve. Okay, so there's nerve roots that come out and they reform into the sciatic nerve. Same thing happens up in your arms, and it's called the brachial plexus. And that those are coming out from the neck, so much higher. So the sciatic nerve reforms, and then you can get the sciatic nerve entrapped at the area that each of these roots is coming out of the spinal foramen, which is the small little canals that the nerve roots are coming out of. So when you're having that pain and you say, well, the pain's going down to my knee, and I say, yes, it's probably coming from your back. And people will say, well, I don't have any back pain. Again, that's the whole idea of this, is to inform you that sciatica, the origin of the pain is the pressure that is placed on the nerve by, and again, it can be bone, it can be synovial tissue, which is just sort of joint tissue, or it can be a disc that has protruded out, but it's pushing on the nerve root itself. And then as you stretch that nerve root, it pushes it more. So people with sciatica, we do what's called a straight leg raise test. So you lay down on the table, or there's also a seated straight leg raise test where you're just sitting in the chair and we straighten your knee out. But typically what we'll do is we'll lay you on the table, and if I pull your leg up to where the bottom of your foot, your leg is straight and the bottom of your foot is pointing towards the top of to the ceiling, and you have pain going down past your knee, that's what we call a tension sign. And what that means is that your nerve's being stretched and it's causing that pain. Okay. So again, the pain in the leg is the symptom, or weakness. You can have weakness at some point as well if it gets bad enough. But the pain in the leg is the symptom, and the cause is the nerve root is being impinged on or pressed on by one of several things: bone, synovial tissue, or the disc itself as it's exiting the spinal canal and out in through the foramen, which is just a little tunnel that it runs through that protects it until, as you age or you have an injury or something like that, and then that canal is disrupted or impinged on. So how do we treat sciatica? Well, the first thing we do with sciatica is we would treat you with anti-inflammatory medications, and that can be either oral steroids or what we call non-steroidal anti-inflammatory medications, which is Motrin, ibuprofen, naproxen, those kind of things. Not Tylenol. I always like to make a distinction. Tylenol is not an anti-inflammatory. It's purely a pain medication. It has no anti-inflammatory properties. So inflammation is the process by which your body reacts to an injury or an illness, and it causes swelling. And like if you get your lip punched, it's going to swell. If you break your arm, it's going to swell. If you have an infection, it's going to swell, because your body is taking different parts of your immune system to get to that area that's injured. And by bringing all that extra material in there, it swells. That's part of the healing process. And then, of course, with an infection, some of the swelling can be the actual multiplication of the bacteria. So you could have a cyst, that has pus in it or those kind of things. So because the pain in either your back or your leg, okay, so here's where it overlaps. So you can have low back pain, and that's going to be coming from the joints in your back, and we're going to give you anti-inflammatory medications because we're going to try to reduce the inflammation in those joints. And that's the same thing we do with the knees and the hips and shoulders, is we try to reduce the inflammation. Then we're going to do physical therapy. And for the back pain, the physical therapy is designed to strengthen your back muscles so that you are supporting yourself better, so there's less stress on all those joints. Or if you have sciatica, again, we will start with anti-inflammatories, because sciatica is almost certainly related to some sort of inflammation. And if we can reduce that inflammation and strengthen your back muscles and hold your back in a better position with less tension on the nerve, your pain can be relieved, whether it's back pain or leg pain. So back pain and sciatica, two different things. I've explained the anatomy. The treatment protocol it starts the same. Now, if the back pain is not getting better, then the pain clinic will do injections into the areas, they're called those facet joints I talked about, and try to reduce the inflammation with a cortisone injection, because cortisone is just an anti-inflammatory. And no, it's not poison. There's a lot of stuff on the internet about how bad cortisone is, despite the fact that all of the data says that it's very safe and it's not harmful. People just like to say that it is. I don't know. I've had a lot of cortisone injections myself, and I've given tens of thousands of them. So I don't know why that keeps coming up. But the injections can also be in the area of the foramen, and they can reduce the inflammation from either the synovium or the slip disc. And then, of course, stretching and strengthening your back. And then the next step, again, now I'm not a spine surgeon. I haven't done a spine surgery rotation in many, many years. I'm still pretty certain that they're not doing spine surgery for back pain, except nowadays they have disc replacements, and that would be for back pain. So there are those kind of things. And sometimes they will do a fusion for back pain. I'll just say that it's a lot less likely, a lot less common. And then sometimes the problem is if you fuse 2 or 3 of your vertebrae, then the ones above and below that start to degenerate too. So it can be kind of a process. So I can tell you, spine surgeons that I know, they would much rather operate on somebody who has a compressed nerve that they can take the compression off of, and those patients just get better. Patients will say they're better on the recovery room table. Like, oh my gosh, my leg pain's gone. Thank you so much. Very rewarding for those spine surgeons. The unfortunate thing is that sometimes the back is really a mess, and they have to do a lot of stuff. But I just wanted to kind of inform about the difference between sciatica and what sciatica is. So let's say it again. The sciatic nerve is a big nerve that is a coalescence of several nerve roots coming out of the spine at different levels, and then they come back and become a nerve, and they run through the back of your hip. Then it becomes the femoral nerve, and then it becomes the popliteal nerve, and then the tibial nerve, and then the peroneal nerve, as it branches off and gets smaller and smaller down to your toes. And at every level, there's branches, and so every level, if you have a compression at any higher level, everything below it could potentially have pain. So there's your spine anatomy for this Sunday. Again, I don't do much with spines. I try to not see them at all. Certainly, because if a patient has low back pain, the primary care docs are pretty good about getting them anti-inflammatories and off to physical therapy. And if it gets past that, typically they're going to need to go see a spine surgeon or the pain clinic or somebody. But I also have pain. I also have a lot of patients who have sitting in my office saying, oh, and I also have back pain. And so, I want to be able to help them in the way that I can. And typically that is, again, starting with anti-inflammatories, physical therapy. If they're not getting better, I will get an MRI, and will then either send them up to the pain clinic for an injection that they do guided by X-ray, or I will send them to the surgeon if it looks like it might be something surgical. But that's the brief overview of spine surgery, and that's spine surgery is a very complex thing, and I've really simplified it. A spine surgeon will typically do either a neurosurgery or an orthopedic surgery residency, and then likely do a spine fellowship on top of it. So it's a lot of training, and there's a lot to know, and I was just trying to give you the briefest overview that can kind of help you understand if you've been told you have sciatica or somebody else says they have sciatica, or what's the difference between back pain and sciatica. And now you know. So I hope everybody's back feels good. One thing you can do is stretch and strengthen your back and walk and get exercise, and it helps all of those things. So getting in the pool is awful good as well. I've been doing that a lot this summer, and it's really got my blood pressure down. I'm feeling good. So I hope everybody else is feeling good. I hope you're having a great day, and you have a blessed week, Iowa.
This has been the St. Anthony Hospital Orthopedic Show with Dr. Richard Godding. For more information about Dr. Godding, his practice, or St. Anthony Hospital Orthopedics, go to www.santanthonyhospital.org or make an appointment by calling 712-794-5536.